section of mood disorders for behavioral science and psychiatry for Falcon Physician Reviews. Now we're going to talk about antidepressant medications and mood stabilizers. First, we'll talk about antidepressant medications. The indications for antidepressant medications include major depressive disorder, dysthymia, bipolar disorder with depressed mood, but they can also be used with a variety of other illnesses such as anxiety disorders, obsessive-compulsive disorder, bulimia, and anorexia. Some of the older antidepressants and some of the newer ones have also been shown to be effective for chronic pain and enuresis. There are different types of antidepressants, and some of the older ones are the tricyclic antidepressants and the monoamine oxidase inhibitors. We frequently do not use them anymore because of their side effect profile and because of safety reasons. Both of these medications can be very dangerous in an overdose. More common medications that are used these days are the selective serotonin reuptake inhibitors, or the SSRIs, because of their decrease in their side effects and because they are generally safe even in an overdose. As well as the SSRIs, we have newer medications such as the SNRIs, which are the serotonin norepinephrine reuptake inhibitors, and the dopamine norepinephrine reuptake inhibitors as well. So we have a lot of new medications that we don't generally need to use the tricyclics and the MAOIs. So how do antidepressants work? We have talked a little bit about it before, but basically they increase the amount of serotonin, norepinephrine, and dopamine. And the main problem with antidepressants is that they don't work immediately. They actually take several weeks to work. And the maximal effect you will get from an antidepressant at the highest dose will be between 6 to 12 weeks of treatment. So the patients have to be on the medications quite a while before they get an adequate amount of treatment. But within 4 weeks, if they show some improvement in their symptoms, then there is a good chance that with that medication the patients will get better in the long run. As we talked about previously, there are different types of medication. There are the SSRIs, which increase the amount of serotonin in the synaptic cleft. There are the SNRIs, which increase both serotonin and norepinephrine in the cleft, and TSAs, or tricyclics, which also have the reuptake of serotonin and norepinephrine in the synaptic cleft. MAOIs block the enzyme monoamine oxidase, which actually breaks down monoamine neurotransmitters in the presynaptic neuron. Therefore, it leaves more neurotransmission for future synaptic transmission. So how are you going to choose the type of antidepressant you're going to use for a patient? Most medications on the first trial will work for a patient and cause remission of their symptoms. But there are certain situations where you might want to consider one medication over another. An example of this would be in atypical depression, where it has been shown that monoamine oxidase inhibitors have been very helpful in treating this. Sometimes you want to look at safety, side effect profiles. Drug-drug interactions will also affect which medication you'll choose. The power of suggestion is also very important, as sometimes patients will come in and say, I have a family member that's been taking this medication, it's been very helpful for them, I'd like to try it. If you don't feel like it would hurt the patient, it could be beneficial. It's sometimes helpful to place them on the medication. Also, if you have a very suicidal patient, someone who's frequently overdosed, you probably would want to stay away from the tricyclic antidepressants and the monoamine oxidase inhibitors, because these medications can be very toxic in overdose. Before switching to another medication, you should try to wait at least 6 to 8 weeks because of the increased time that it takes for these medication works before you try augmentation or switching to another medication. We usually recommend that you at least try 2 SSRIs, an SNRI, 2 TCAs or MAOIs before considering neuromodulation with electroconvulsive therapy, vagal nerve stimulation, or transcranial magnetic stimulation therapy. SSRIs have the least amount of side effects than other antidepressants. The most frequent side effects are nausea, vomiting, diarrhea, and the reason for these gastrointestinal side effects is that you have a lot of serotonin receptors in your GI tract. Also, some people will know that they're more irritable, they're more anxious when they first start taking it, and if you start them at a lower dose, then you can prevent these side effects. And some people will have the insomnia and sexual side effects such as delayed ejaculation, and this can be treated by adding bupropion, which is another antidepressant medication, or switching to another antidepressant medication. Another very important side effect that's very rare with the SSRIs is serotonin syndrome, and that is if you combine an SSRI and an MAOI together. And if you are taking an SSRI, they recommend that you wait at least 2 weeks before you get started on an MAOI, and this is to prevent serotonin syndrome. If you're on fluoxetine, they recommend that you wait at least 5 weeks before you start on an MAOI because of the long half-life of fluoxetine. So what is serotonin syndrome? Serotonin syndrome consists of tachycardia, high blood pressure, myoclonus, shivers, trembling, and this is potentially life-threatening, and what you should first do is remove all of the antidepressant agents and give IV fluids and supportive care. After a couple of weeks, you can retry them on an antidepressant medication. Monoamine oxidase inhibitors are a very effective treatment. They're cheap, and they can help for major depression and anxiety disorders, especially helpful for atypical depression. But they have some side effects that are very troublesome. One, they can cause a lot of orthostatic hypertension, and an important USMLE point is that if you're taking a monoamine oxidase inhibitor, you have to be on a tyramine-free diet, which means that tyramine-containing foods such as red wine, cured meat, certain types of aged cheese, beer, you cannot eat, and you can't take over-the-counter cough medications, because what happens is you'll have a hypertensive crisis that can lead to a massive MI or a stroke. The treatment of this will be IV phentolamine or nitroprusside. That is a USMLE question. Other side effects can include sedation and weight gain. So that's the problem with the MAOIs, is that the diet is very hard for people to maintain. They might accidentally eat something with tyramine and have them to cause these hypertensive crises. So unless some other medication is just not working, a safer medication, then you generally don't go to the MAOI. But on your exam, if you have someone with atypical depression, put an MAOI as a treatment. Tricyclic antidepressants are also very, very good antidepressants. They work just as well as the serotonin reuptake inhibitors, but again, the problem is their side effects. They have very many anticholinergic side effects, a lot of orthostatic hypotension, constipation, dry mouth, sedation. Especially in the elderly, you have to worry about anticholinergic side effects because it can cause confusion. You also have to be aware of any kind of cardiac toxicity with the tricyclics. They can cause conduction abnormalities. And in an acute toxicity, they can cause an AV block, widening of the QRS complex, tachycardia, and ventricular fibrillation. You do not want to give a patient with a first-degree or second-degree heart block a tricyclic antidepressant. Then you have your SNRIs, or your serotonin norepinephrine reuptake inhibitors. And an example of this is venlafaxine and duloxetine. Venlafaxine has very similar side effects to the SSRIs, with the addition of sweating, and also it increases diastolic blood pressure. Venlafaxine also has a very short half-life, therefore when you are tapering the patient off the medication, you have to do a slow taper to prevent a withdrawal syndrome. Paxil or paroxetine can also have a very similar abrupt discontinuation syndrome if you do not slowly taper them off these medications. It's not deadly, but it's very, very uncomfortable. Duloxetine is a newer SNRI which has come out into the market, and it has the main side effects for it is going to be stomach upset. Duloxetine is also being marketed as a diabetic neuropathy medication. Other medications include mirtazapine, which works on the alpha-2 adrenergic autoreceptors, but it doesn't inhibit reuptake of serotonin or noradrenaline. The benefits of mirtazapine is that it also works on histamine. So it's a very good medication for people who are not sleeping well, who are not eating well. This medication will help them sleep and it will increase their appetite. Also, because it doesn't work on serotonin like the other medications do, it does not cause any sexual dysfunction. So therefore, it is a good medication if you're having problems with that. Bupropion works both on dopamine and norepinephrine. It has stimulant-like effects. The problem with bupropion is that at higher doses it can cause seizures. So if you have a patient with a seizure disorder or with an eating disorder like bulimia who's vomiting and has electrolyte abnormalities, you don't want to give them bupropion, which can cause a seizure. So those are contraindications, as well as if you're having any kind of alcohol withdrawal state, a history of seizures when you're withdrawing, you don't want to put that person on bupropion. Also, this medication has very little risk of sexual side effects. There is no weight gain with this medication. The main side effects are going to be insomnia and stomach upset. Other medications include trazodone, and the most important point to know about trazodone is that it's a medication that is an antidepressant, but we don't use it at the higher doses as an antidepressant, but use it at much lower doses to help with sleep. And the U.S. side effect you must know is priapism, which is a painful, sustained erection when people take trazodone. It is not very common, and you must go into the ER and have surgical correction if that does happen. So here's a list of very important points to remember for your USMLE exam questions. These are all very high yield points. So imipramine, which is a tricyclic antidepressant, is used to treat enuresis. Nortriptyline is the least orthostatic tricyclic antidepressant. So if you have an elderly patient who you're worried about the risk of falling, you'll put them on nortriptyline. Clomipramine is the most serotonergic tricyclic antidepressant and hence used for obsessive compulsive disorder. Doxepine is the most antihistaminergic tricyclic antidepressant. That is an exam question. Fluvoxamine is very effective for treating obsessive compulsive disorder, and it's a serotonin reuptake inhibitor. Trazodone, priapism is the big question that they'll always ask on the exams. Bupropion, there's the least amount of sexual side effects. Do not use them in seizure disorders, and it also has the least potential for manic switch. And MAOIs, remember atypical depression and the food interaction with tyramine. Other therapies that you can use for depression are electroconvulsive therapy. Patients usually respond to this very quickly within about 2.5 weeks, and treatments are given 3 times a week, and normal treatments are between about 10 to 15. And there's a very good remission rate with ECT. It's higher than just with antidepressant medications, but it is not a first-line treatment. It is usually used if all other treatments have failed. And how it works is it causes a generalized seizure, and the most common side effects are going to be some short-term memory loss. Phototherapy is used for seasonal affective therapy, but you must be careful because sometimes phototherapy might elicit mania in a patient with bipolar disorder. Next, we're going to go into mood stabilizers. So why do we use mood stabilizers? We'll use them in bipolar disorder, cyclothymia, someone with schizoaffective disorder, which we will later talk about in our psychosis section. Also, they can be used to augment antidepressant treatment if all other treatments have failed. How do these medications work? It is still quite unclear how the medications work and which neurotransmitters that they work on. This is not going to be a high-yield question for you to know on your exam. Lithium changes the balance of intracellular cyclic AMP and the phosphatidylinositol pathway. It is a monovalent cation, and it can act like sodium and bind ion channels. So when you have a patient on lithium, it's very important to let them know that they must keep a stable sodium content in their diet because it binds to the same receptors as sodium. So if they don't take enough sodium, then more lithium will bind to their receptors and they'll become toxic. If they eat too much sodium, then they won't have enough lithium and it will be therapeutic. So therefore, they have to keep a stable amount of sodium, a stable amount of water intake when they're taking lithium. Next, we have carbamazepine and valproate. These are also anti-seizure medications which have been very helpful in mood stabilization. Carbamazepine decreases the amount of neurotransmitter released from the presynaptic neurons in the central nervous system. And valproate seems to enhance GABA activity and decreases the degradation of GABA in the CNS. And GABA is an inhibitory neurotransmitter, so that makes sense that if it increases GABA, that means it'll help decrease a manic state and keep them stabilized. So how do you choose medications? If you have a patient with a first episode of mania, then you can choose lithium, valproate. You might even want to choose an atypical antipsychotic as all first-line treatments of acute mania. Carbamazepine can be a first line, but if you have the choice of lithium or valproate, instead use carbamazepine. Don't use carbamazepine, use those other two. If you have a severe episode and you need to treat them very, very quickly, you might want to add lithium and an antipsychotic together, because the antipsychotic will actually work faster than the lithium will, and then eventually you can withdraw the antipsychotic. Most of the atypical antipsychotics now have FDA use for bipolar disorder, so it is an FDA-indicated treatment. Remember to always discontinue an antidepressant when you have a manic episode. You can add them back later on if the patient is depressed once they're on a mood stabilizer. Valproate is effective for mixed episodes, and lithium seems to be more effective for people who have more depressive episodes and suicidality. Lithium has shown to decrease suicidality in patients with bipolar disorder and depression. Also, lamotrigine is also very helpful in patients who have bipolar disorder, but most of their symptoms are depression. And the maintenance treatment, the best evidence is shown for lithium and valproate, and also you can use atypical antipsychotics and carbamazepine. Lithium levels should be checked regularly until you have a stable therapeutic effect. For lithium, you also must monitor their thyroid and their kidney function, and these are two USMLE high-yield points. It can cause hypothyroidism and diabetes insipidus. Other side effects of lithium can be tremor, GI upset, headache, acne, weight gain. You should not use it in the first trimester of pregnancy because the possibility of Epstein's anomaly, which is an anomaly of the tricuspid valve. Also, you must make sure that you're monitoring different medications while they're taking lithium. You don't want to use certain diuretics, nonsteroidal, anti-inflammatory medications, because they can cause changes in their lithium level. The nephrogenic diabetes of lithium can be treated with amiloride, and the hypothyroidism on lithium can be treated by just replacing the thyroid hormone. You don't have to stop the medication. Valproate, the common side effects of valproate will be sedation, GI upset, hepatotoxicity. You must monitor the liver function tests initially, and rarely it can cause pancreatitis. Carbamazepine will also have similar side effects, but it can also cause agranulocytosis, pancytopenia, and hepatotoxicity. This concludes